Go for it, Kathy.
Okay, so yeah, just for those of you who don't or do know, this is going to be a very different session to the very organised ones that Jane's been running. This is a very ad hoc live, like a stand-up comedy sort of show. And so we did run one on Monday, which was great. We really enjoyed it. And this is a repeat of the Monday one, just because we recognise that there are people who can't sometimes come to the Wednesday one. So let's start with our karakia. Tūtau wai mai I runga, tūtau mai I raro, tūtau mai I roto, tūtau mai I waho, ki tau ai, te Māori tū, te Māori ora, ki te katoa, humie, huie, taikie. All right. As per usual, we're going to go into little breakout groups, which Jane will put us in. And I'd like you just to, if you don't know who's in the group with you, just do a quick little introduction. And then I'd like you all to answer these two questions. In which 3 months of the year is the data for the snapshot collected? And then also, why is it called a snapshot audit? All right, so you might want to take a photo of those two questions if you can't remember them. So basically, which 3 months of the year do we collect the data and why is it called a snapshot audit? All right, so Jane, if you're fired. Oh, thanks, Jane. Yeah, so that's what this snapshot audit is about, a snapshot in time. Okay, great, thank you. Let me get rid of this big gallery of people, put you over here. Okay, so as I mentioned before, this is Snapshot Session 4, and today we're going to be looking at entering the data. How does that actually work? For those of you who don't know, where am I up to? For those of you who don't know, we have done VIP webinars for 1, 2, and 3, and as Jane mentioned before, they are available for you to view if you want to go back and watch them. Thank you. Okay, so this slide we've been using each time, and it's just a reminder to you that at the moment we are in the planning phase. Even though we are in April, at the moment what's happening is these patients from April, May, June are now entering our hospital systems. So these are the patients that we are going to be auditing, but we can't audit them until July, August, because we need them to have been in the system and have time for that information to be recorded in their clinical notes or whatever it is that we're auditing. Yep. Okay. Don't lift the paddle out of unison. Now, this is two things. First of all, Jane and I were very pleased when we went on the database and noticed that nobody was actually entering data yet, which is great. We don't want you to enter it yet. And just a reminder that we're all paddling this together, because I personally use this data quite a bit when I'm doing teaching or I'm doing in-service in areas, and it's really valuable to be able to go to, say, for example, emergency department and say, okay, you've got a 0 routine inquiry rate, but because of the snapshot audit, I can see that Southland has got 60%. And so maybe we could contact the Southland ED people and find out what is it that they managed to do, and could we possibly do that as well? So yeah, it's about all paddling together. Going along with the boat theme, I'm also very aware that in Auckland we are sometimes viewed as the luxury liner, because we do have the digital records and it makes it much easier for us to be able to audit. Some of you are not luxury liners, some of you are the leaky rowboat, but we all still have a boat, and it's very important that we all use that boat to get what we can out of it. Also, what I'm talking about here today is purely from my 150 years experience of doing this work. So I'm very aware that what I do here may or may not work for you, but that's why Jane and I are so thrilled that we're actually getting some communication from coordinators to find out, just because you say to do it this way, I have a problem with that because of blah, blah, blah. and then we can all work it out together. And in joining the evaluation team and in putting together this information on VIP Snapshot, I have learned a huge amount myself, which I kind of wish I'd knew right back at the beginning when I was actually doing these. So yeah, thank you. So as I mentioned, we are still in the planning phase, but that doesn't mean we're not doing anything. So in this phase, this is what we're thinking about. We're thinking about, do we have, or will we eventually get in July, as soon as possible, the list of NHIs that we are going to be auditing for each of the services? Have I sorted out who is going to audit which data? Now, for many of you, it will be you. For example, our sexual health service is a regional service and they have their own database called HCC Community, and we don't have access to that as family violence coordinators. We probably could get access to it. However, there is huge value in me sending, and I'll show you how I do that in a minute, the list of NHIs to our sexual health champion saying, it's snapshot time again. Can you please have a look at this list and audit them and get back to me? Because they learn a huge amount from doing that. Jane, we've got your Teams view, is that right? Or I've got my Teams view, sorry, that was me. Okay, please log on to your database, and we're going to have a quick talk about that in a minute, and play with it. It's nothing to be scared about. It's like buying a house. Once you've written a contract once and realised that you can back out of it easily, it's the same thing with the database. We don't want you to think, oh my gosh, I can't go on there until I'm absolutely ready. We want you to be a little bit more familiar with it and have a look at it. Okay? Jane, I'm going to see if I can do this from my end today because I'm trying to get more technical. So I'm going to share my screen like this, and not that one. Hold on, this one. Okay, so depending on which search engine you use, and we had massive problems with our search engines this morning. Hold on. I can't see the top. Okay, so I've got so many things on my screen, I can't get to the top search engine bar. Oh, here we go. So I'm going to put in here VIP or AUT or whatever you want to put, Snapshot log in. Okay, and this is what I will get. Most search engines will bring up the same format, okay? So I'm looking for the VIP snapshot. I'm going to click on it there. It then brings me into this field, okay? So for today, actually, I'm going to show you the ADHB one, or the Te Tokotumo one. So this is your work email that you put in there. And after you've logged on once, it will ask you to change your password, or if you haven't logged on before, you can just put your email address in there and hit forgot password, and it will email you out a password. Okay, so you can see that this is bringing up for me our history for Auckland of what we've been doing as far as VIP snapshot auditing goes. Now, Jane and I are pretty sure that if I was brand new in this job and someone else had done all of this prior to me, just because I'm Auckland, it brings up Auckland's historical information on this database. It doesn't matter if you weren't the last person to do it. And you can see it's organised here for postnatal, adult emergency, sexual health, child health inpatient, child emergency department. Now, I'll talk about that in a minute. Alcohol and drug, and community mental health services. Okay. So if I use this first one just to show you, you can see that the last time an audit was done was November 9th, 2021. There was 25 patients. It was an official one. It was completed. If it wasn't completed, that would read in progress. And then it's telling you in this graph below that in 2015, our routine inquiry rate in postnatal was 76%. So you can see it's showing me that figure there. And then in 2021, it was 8%. So, you know, as you can see, we're doing really, really well. Not. But it will do that for each one of the services that you are entering this VIP snapshot data into. Just to mention here, in the child health one, we are measuring family violence routine inquiry of the female caregiver of the child. And in this one here, we are measuring the child protection checklist, which is completed in children's or in the emergency department. All right. Now, at this point, are there any questions or comments? Okay. Nothing in the chat, Jane? Oh, hold on. What does this say? No, no new chats. Okay. Please feel free if you've got any questions or comments just to pipe up. You don't have to hold them till the end. Now, if I was going to be doing, okay, now hold on. I'm going to go back to the PowerPoint, please, Jane. Oh, you're muted. Oh, I have to stop sharing. You're right. Yes. Sorry.
No worries.
I'm so good at this technical stuff. Okay. Now, what happens for me is that I request the data that I need for this from our IT services. And that is done by sending them the information sheet, which we talked about in the previous webinars, saying basically this is what the audit's all about. This is when the data is required, and this is what we need. I have a cover sheet on my spreadsheet that they send me, and you can see here that it's telling me for this period, April to June, in AED, there was 9,669 eligible patients seen. So this is not the total number. This is of the eligible patients for that ED. So the eligibility for ED will be slightly different to the eligibility for, for example, postnatal or pediatrics. And all that information is in that document that you will hopefully have already sent, and if not, we'll be sending very soon to your IT services or your quality and risk people, so that people know that you need that. And I'll tell you why you need that number in a minute. Okay, next one. So that's the cover sheet that we get. And then the next bit of information that we get is something like this. So obviously this is AED because it tells you that in column A. I will get a spreadsheet that will have a whole lot of tabs on the bottom saying, here's the data from postnatal, here's the data from AED, here's the data from whatever. It will tell you the triage number because that's required for AED as far as the snapshot audit goes. And as far as I know, the triage number just tells you how serious or what was, what was the risk level of that patient. They give us the admission date and the discharge date. As we know for AEDs, they try and get their patients in and out within 6 hours. But for example, the postnatal wards, we're actually really interested in only getting eligible patients who've been there for a minimum of 24 hours so that we can be sure that they've had a reasonable amount of time to be able to ask about family violence. Like, we don't want people who've just popped in for, I don't know, a 5-minute procedure and they're back out the door again. That will skew our results slightly. The purple column, which you can't see there, will have the NHIs and the date of birth of those patients. The next column will tell us the age of the patient, and then it will tell us their ethnicity. And in the previous webinars, we talked about how we find that ethnicity data. You can see that these are all females, which is great because that's all we want. As we know, it's not true, it's not all we want, but that's all we kind of are auditing because of the Ministry of Health guidelines. The next 3 columns, I add that onto the spreadsheet. So I put routine inquiry in one column, disclosure in another column, and then whether it was active or passive in the next column. So if you could pull up the next one, please, Jane. This is just an example of, we've now swapped to women's health, you can see. And it's just in a slightly different, order. So the age comes after the number. So, for example, if I was getting my champion in women's health to do the auditing for these women, I would send him or her a spreadsheet that looks a bit like this, and they would be recording for me. This is patient 1 who's 28 years old. The NHI, obviously they get that so that they know who they're auditing. This is the date that the person was admitted. This is their ethnicity. And then they're going to record for me, were they asked about family violence? So that's why it says yes or no routine inquiry. If there's no routine inquiry, then obviously they can't fill in if there was a disclosure and whether it was an active or passive referral. So if you go down to patient number 9, you can see that, yes, this person was asked about family violence and there was no disclosure. So if there was 2 yeses, then they would need to complete the field on, was there an active or passive referral done? Now, they can print this out and fill it in by hand and scan it and send it back to me, or they can fill it in on the computer, whatever they feel most comfortable with. But what it means is that, say they're a person working in women's health and they get up to patient number 5 and they get called to go and do something, that's fine. They just know when they come back, oh yeah, I did patient 5, so now I'm on to patient 6 and I need to put that NHI in and I need to have a look either digitally or through the notes to find out what their routine inquiry was. And then they just send it back to me. So I am the only one that enters the information in the database, but by sending it to them in this format, we're getting the same information, standard information from each champion. Now, any questions or comments? No? Okay, so I've got the spreadsheet in front of me, and this time I'm actually going to go back into the VIP snapshot log on. Okay, so Jane and I have set up a special training one. So this time, no, this is what it does sometimes. It automatically assumes I'm Auckland, which this time, don't you hate it? Don't you hate it when computers do the thinking for you? I want to go in here and put my home address. And okay, so this time you can see this is the training version that we're using. So say I was working on that, the champion had sent me that spreadsheet that I just showed you. You can see we started doing some work on this the other day, so it's still in progress. So now I'm going to go in there and I'm going to edit the progress that I've already done. Actually, I should just use a new one, shouldn't I? That would be easier. Okay. I need to. So where's my option for completed? Here, progress change. Sorry, it's just that you're hidden under the gallery. That's why.
I think you'd need to change to a different service, Kathy, to start fresh. Yeah.
Shall I see if I can do it this way? Oh, no. There we go. So same service. So I'm going to do an official Snapshot audit, okay? And my DHB is Auckland. And it's asking me, is the Starship Hospital or Auckland Hospital? I'm saying it's Auckland Hospital because it's women's health. Do you know the current percentage of staff who have done core training in that designated service? We never know the answer to that because we have such a throughput of staff that it changes at a minute's notice, the number of staff who are on that ward. So I always put no. Some of you may know that, and that's absolutely fine. And then this is where on the cover sheet that I showed you at the beginning, this is the total number of eligible patients. That's why that number is very important. So say I'm going to put in 1,200, okay, and then I'm going to go save. And so it's telling me this is patient 1. And that's why I also found it useful to have those numbers down the left-hand column of the spreadsheet, so that if I was doing this and somebody interrupted me, I can see quite clearly, okay, that was patient 1. And then it will tell me, I can easily see which patient I'm up to. So patient 1 was Southeast Asian, and so I'm going to put other. And they weren't asked about family violence. So I'm going to put no, and then I'm going to put save. All right. Say patient 2 was New Zealand European. And yes, they were asked about family violence. And yes, they did disclose. So these categories only pop up if you click the correct bit. So if I said no, they had disclosed, I don't get the option to say whether it was active or passive. You only get that if you click the yes button here. And then this is basically active or passive, and Jane went over in the previous webinars how you decide that. And so I'm going to say, yes, this person got on-site. And that's all I need to enter. And then I click save, and it will bring me up my next patient. Now, at any point, I can go back and edit. So say I'm in busy and I think, oh, God, no, that was for patient 6, not patient 7. Doesn't matter. You can go back and you can edit where you were up to by choosing the patient. Okay, any questions or comments?
Kathy, Sally asked about the difference between off-site and on-site referral.
Okay. It's the same as active and passive in that on-site referral means basically you're putting them in contact with somebody on-site, like now while they are here in our hospital, whether that be for 24 hours or whether that be for 24 days. It might be that the hospital social worker comes to see them and that social worker does a proper assessment around family violence. We're lucky here in that we have a Shine advocate working here with us at the hospital. You may have Women's Refuge that comes into the hospital if required. Those are all on-site. Off-site is more that you give them a Shine card or a number and say, if you do need services, you could contact these people or Women's Refuge. Does that make sense? Yep. Okay. Any other questions or comments?
Sorry, just double checking with the off-site side of things. You said giving them a card side of things, but if you actually referred to them, but they're going to see them when when they've left or been discharged, is that classified as on-site or off-site?
I would personally classify that as off-site because unless we audit if that person actually does make contact with that service, and I would have to say probably most of us don't, then we're really not sure whether they did make contact or not.
I think, Bailey, though, what I really like about that question is it does bring up a nuance of sometimes what I talk about in terms of referrals are whether they're warm referrals. So I think when you actually say, refer to a service and say, Mary is expecting your call tomorrow, or Mary is going to stop by and do a visit tomorrow, or something like that, where you actually are making a relationship, a connection. So I would call that a warm referral. So even though it is not on site, you've done a warm referral. And I think that's, it would be great if we could add more categories in the referrals, but we are trying to keep it as simple and easy to get through the data entry as possible. So while there's many things we'd like to collect, we've tried to keep it down to a minimum. So, but that's a really good question. And it raises the issue of what is our best practice, and perhaps in doing in-depth audits, that's something that you may want to collect on a certain service when you're making improvements.
Yeah, really good question, Bailey. I think it just reminds us why we call this a snapshot audit. There's nothing stopping you doing this audit and adding another 150 columns on the end of your spreadsheet. And while you're doing it and you've got the charts in front of you, like for example, if you're particularly interested how many of these people have been strangled, whatever, you could easily do that, but you're not required to input that data because, as Jane said, we're trying to keep this as simple as possible. Does that make sense?
No, that's cool. It's just I was thinking of like more communities would refer rather than have them come to their visits or whatnot. So I was just kind of working that out. Cool. Thank you.
I think it's important. It's still a referral. It's not a no. It's still a referral, and that's important, because the other thing is we all know that when we assess level of risk, not everybody is about to get killed today, but it's just as important that those people still get the option of knowing what the referral options are for them in the community. Now, one question that was asked on Monday, which you might find interesting. Oh, Nikki, you've unmuted. Did you want to ask something?
Yeah, I did. Sorry, guys. It's a good bit of it bug. What about if you've got a dual referral? So say the patient comes in through ED and it's a woman, and we have an ED social worker, but they're only part-time. So the staff may do two referrals, one to give them the woman's refuge details, as well as do a referral to our social worker in ED. What do we mark that one? Is it like, is there a certain one that trumps? Is it?
I think the referral is, did the social worker respond to the woman while she was in the emergency department?
Well, often we won't know because they will often not put their note on the ED note. So I'll put their own notes into the social work file. Yeah. So we'd have to chase that up and follow it, which we can.
Yeah. I think it's just a referral, an offsite referral, until you get your system where you can easily follow that up.
Yeah.
So where you can, for that, it would be really good if the system allowed you to know whether or not someone saw a social worker while they were in the department, wherever that might be. That seems important. It seems important for the care of that woman that the staff would have an understanding when they either get discharged or the plan of, a safe discharge plan is made, that people would know whether that secondary assessment, I'll call it, an intervention was done.
I think we just call between half of it's electronic and the other half of it's paper notes that then get loaded electronic. So there's always that delay.
I often get quite excited about questions like that, Nicola, because I'm a bit of a geek when it comes to numbers and things. And if it was me, I'd be using the patients that you're already looking at in the snapshot audit and then doing a follow-up PDSA on, do we know how many of them who get referred actually get seen? And you could use these 25 random NHIs as your start point.
Well, it's certainly been something that's come out of ED before with our social work, sorry to deviate, only because the time the social worker gets down there, because she dual covers other areas and other wards, that person's already been discharged and left. So it's an opportunity lost.
Yeah, and is there something else that you could do to close that gap and stop that opportunity being lost? I'm not saying there is or there isn't, but is there something else? And I realise a lot of it comes down to resource that the social workers just aren't around all of the time. But could the nurses do a little bit more when they do their routine inquiry and fill out their risk assessments? Like, why do we think that the social worker has to do it all? Is there, and I'm not saying the nurses have to become overnight social workers, but is there something a little bit more that they could do?
Agree.
Okay, thanks. Beverly, do you want to just mention your questions that you were asking Jane before, just in summary? You're muted, Beverly.
I always do that. Start, Beverly. I was just asking, I sent an email to Jane earlier around sexual health and the number of presentations, because the clinic tell me that sometimes they will see a client, and are we capturing? So what are we? Which presentation are we looking at? Can be a number of follow-ups, or there may be a follow-up which is a very short interaction. It might be picking up a script or just grabbing some more condoms or something like that. And they're feeling that there could be a number of follow-up brief appointments. So I was just trying to clarify what we're looking at in the snapshot and where we capture that routine inquiry, or where we're looking for it. Does that make sense?
So I think in a lot of the services, it is about having these conversations with the clinical service. So what is the expectation? According to the family violence guidelines, it says if there's a sexual health visit, that there would be a routine inquiry. So talking to your service, what do they consider a visit? So it makes sense to me if someone comes in and has a issue with their sexual health, they come in and they get an assessment. And the expectation, I think, is that included in that assessment would be talking about family violence, a routine inquiry for intimate partner violence. So it is about talking with the service. So if they come back and pick up a script or drop off a sample or something like that, how does that get recorded in the system? So is there a way to differentiate those visits that engage in where an assessment is expected versus a follow-up visit? So I think it is talking with your service and maybe the IT people to see if you can discriminate between those.
Our sexual health service currently use medtech, so it's very like a GP practice. So yeah, that
yep. So medtech, like if someone comes in for a script or something like that, I would think that it would get categorized differently in medtech. So it is just working out with them based on their system, ask them to help you. Be clear on which visits would you expect a routine inquiry to be part of an intake assessment, similar to what we do in community mental health. And alcohol and drug and community mental health, we've kind of said it can occur over the first couple visits because oftentimes there's a crisis in priorities. So we know that a mental health intake assessment may occur over 2 visits, for example, whereas in sexual health, maybe that initial assessment, it may just occur at that first visit. And they may have follow-up or they may not.
And what if they come back again for something else in that 3-month period?
Yeah, that's a good question. The same happens in the emergency department. So when people come into the emergency department, a woman may come in for an injury at the beginning of the 3 months, and then she may come back in 2 months later for something for asthma, or something like that. And each of those visits, there would be per the guidelines, it would be expected that there would be an assessment for family violence, for intimate partner violence. So it kind of does go back to the routine inquiry. It adds a little bit of complication, and we'll explore this with the IT people as well and our biostatistician. So ED visits should be asked if they have a different presentation. They should be asked again. And we'll ask, the statistical issue with this is called sampling with or without replacement. So does everybody just get in the database once? Or if somebody has 5 visits, 1 visit and 4 follow-up visits, a random sample may include that woman more than once. So it's quite a complex issue. And we're going to have a conversation with our team and come up with some directions, Bev. So thanks for raising it. Unfortunately, I don't have a yes or no answer for you now. But those are the questions we really want to get, because we want to sort it out so people are collecting it the same way across nationally.
Yeah, just to reinforce that, absolutely. That was a fantastic question, Beverly, so that we can try and use that on nationally as well. I just replied to the email that I know that what we do here at Auckland is that, for example, if a nurse records that she didn't do a routine inquiry because the person had already had one 3 months ago, and I know that 12-month often comes up in staff's heads, we still count that as no routine inquiry, because we actually want them to ask every time that person comes in for 2 reasons. First of all, we don't know if something's changed since we last saw them, nor do we know whether the first time we asked them they said no, but actually they wanted to disclose. So it just gives them another opportunity to do that. I do know that in our sexual health clinic, because they do see a lot of patients quite often, rather than rolling straight into the 4 questions straight off, they often say, when we saw you a month ago, we asked you some questions around family violence. I'm just wondering, has anything changed since then, or have you had a new partner? And then they can glean from that whether they need to go on and ask those questions again.
So just a quick question on, so are we recording, so say someone does present to emergency department with an injury and then a asthma or something, are we recording both of those events? Or, one might be they were routinely, routine inquiry did happen, and another one maybe not. So
I think for Bev, what happens up here is the random data that we get doesn't give a date of when they presented or that happened. So we just kind of look at that period, I guess, in that sense. Whereas your guys has the event or the time that they were seen. So it gets a bit tricky for us.
Mm.
So off the top of my head, Jane, I can't remember if the eligibility criteria for AED is patients or visits.
It's visits.
It's visits. Okay, well then that's fine, because the numbers down your spreadsheet, Beverly, will be visit 1 to visit 25. And say 6 of those visits were the same patient. It doesn't matter, because you're entering that information into the database as visits, not patients. We're not entering the NHI.
I think if 6 of the 25 were the same person, I think that should initiate a call to Jane.
Yeah. Okay, that was a slight exaggeration. Say it's twice. Okay. But also I think this is a really important thing that, people realise that the information that we're requesting from our IT services, they need to also be very clear. Are we talking about patients, as in we don't want any repeat NHIs because it's one person at a time, or are we talking about visits? And that's quite clear in the VIP snapshot information that we send to IT, but we need to know it ourselves.
Yeah. I mean, the one for sure, even in mental health and alcohol and drug, it's the eligibility, and what we're counting is new clients. So someone can only be in the database as a new client. So sometimes after someone's treatment plan is put in place, they'll be exited from as a client, and they may come back again as another and be another new client with a full assessment. So that it is the point of being a new client in community mental health and alcohol and drug services. Whereas the other services are much more likely to be episodic and are much more focused on visits. But yeah, it does raise some issues. So Kathy, did you want to, we've got 8 minutes left to the hour?
Yeah. I was just going to say that's basically all we wanted to talk about today. But you will note that we have another session booked for June, which is sort of a curly questions, and I'm already working up some quiz questions like who wants to be a millionaire when it comes to VIP snapshot. But also, we want you to. We don't have to hold your questions till then. We want you to make contact with Jane and I and see if we can figure these things out. And maybe also what we need to do is in between somewhere in July and August, do another get together like this where people are actually underway entering information in their databases, and those who haven't even started it yet can get some support from those people who are actually giving it a go already. So maybe that's something. Would that be helpful?
Yes.
Okay. All right. Maybe we'll look at that. So shall I call us to a close then? Is there any more questions or comments? No? Okay. Let me just pull up my...
No, I think it's real helpful. And I kind of feel like for myself, you know how sometimes you have to almost be in the doing to really, it'll probably be then that we'll be screaming on the phone call, even though you've done it with this wonderful preparation. No, because you've recorded these and we can go back and remind ourselves.
Yeah, well, we can, but also there's nothing like doing it live personally.
Yeah.
You know, it's nothing like being able to do a panel session like this when you guys are actually the panel. You know, to be able to say to another coordinator, I haven't even logged onto my database yet, was that hard? Those sorts of things.
And just so you know, I noticed, Kathy, that one of the slides had a date of birth on it. So I'm going to need to block that out because that's...
Yeah, sorry. That was my fault.
So we'll need to do that. So we may not post the video, but certainly the slides will post without that identifying information on there. But we're available at just an email or a phone call.
Okay. Jane, I haven't got the PowerPoint. Would you be able to close us, please?
Sure. Absolutely. Kia whakaria te tapu, kia wā te ai te ara, kia turuki whakataha ai, kia turuki whakataha ai, homie, huye, aikie. Good to see everybody.
Thanks, everybody. Thanks for your
Happy to.
discussion.
Yeah,
See you,
thanks,
Nikki.
Kathy.
Nice.
See you, ladies. Nice to
See you, Rebecca.
Yeah.
Oh, actually, while you're still on here, Rebecca, just thank you, everybody, for replying about the date for us to meet.
Are we landing?
Nationally. I felt a bit nasty, or felt a bit bad having to email Kathy Phillips and saying we're just waiting for you, but